it's important for all of us to know where we're standing and take the time to think about it. I personally, I am in Toronto, the land of many First Nations, Indigenous, many First Nations, Inuit and Métis people, particularly those who are the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee people, and the Huron-Wendat. And with that recognition, it's important to understand where I am right now, that this land has been has a long history of and continuous history of colonization, and there has been people who were removed from this land for myself to be able to live, work, and love in this land. And I'm grateful for those who've come before us, but also understanding that Indigenous peoples and is not only about traditional land, but also enduring and continuous, and to think about continuous the future of Indigenous people in this land. So with that, I don't know, Caroline, if we can mute the dings. It's a bit distracting. Okay, if not, we will just have to go live with the dings. So I just wanted to start off in the second slide with a disclaimer, just understanding that this product has been created by Public Health Ontario staff, and that it can be replicated for the purpose of education, but cannot be changed without permission of the WHO. And also, I would like to acknowledge my two amazing team members and co-presenters today. Dr. Tamis, who's a public health physician with the Health Promotion, Chronic Disease and Injury Prevention, and Caroline Bennett-Abayash, who is an allergy exchange specialist. There is also a slew of team members in the background that have supported us, from library services to communication to technical people with technical expertise that we would like to offer our gratitude to for today. I also like to acknowledge and welcome our co-partners in this work from the Ministry of Health. So I would like to welcome Yolande Davidson, who is the Director of Indigenous and French Language and Priority Population Branch with the Strategic Policy Planning and French Language Services Division at the Ministry of Health. Yolande, I welcome you to say a few words to welcome folks and also introduce your team. Thank you.
Thanks so much, Samia, and thank you to the team at Public Health Ontario, who have been great partners with us as we've been doing this work together over the last several weeks. So again, my name is Yolande Davidson, and I'm the Director of the Indigenous French Language and Priority Populations Branch at the Ministry of Health in our Strategic Policy Planning and French Language Services Division. With me are my colleagues, Carly Hay, who is the manager of the Health Equity Policy Unit on my team, as well as Mitchell Guerrero, who is a senior advisor on that team. And we, among many others in the ministry who've collaborated and provided support for this effort, have been working on implementing or establishing an approach to implement the collection of sociodemographic data in vaccine rollout. Many folks on the line may be familiar with the collection of sociodemographic data through the testing phase of COVID response, which is ongoing, and that would be the collection of data related to positive COVID-19 cases. So this is a continuation of that effort now that we are moving into the vaccination phase, to continue to be able to capture data about the experiences that different communities are having with respect to vaccination. But I know there will be more said about that later on in the presentation, so I will stop there. Thanks so much.
Thank you, Yolande. So first of all, just to start us off, we wanted to ask a few questions to gain an understanding of, first of all, the first few poll questions, including where we are, where you're all calling in from. We know we have a representation from across the province, so we just wanted to understand who is in the room with us. I think I'm going to give 30 seconds for folks to fill that poll. Great. Wonderful. The second question that we wanted to know is gain an understanding of the different organizations that are represented in this webinar, understanding that vaccine distribution and administration will be at different settings. So just understanding who's with us in terms of the type of organization you work at. Great. So we see that predominantly we are public health, local public health folks in the room, and then we have some community health and hospital representation, as well as long-term care and academic institutions. The last question that we wanted to start us off with, just to understand the level of your current experience around sociodemographic data collection. Great. And it looks like we have almost a perfect mix of folks in terms of different levels of knowledge and expertise in this area. Thank you so much to all of you for giving us an idea of who's in the room with us today. So just quickly to go through today, we've done the welcome and acknowledgement. We're going to go through quickly going through why collecting the social demographic data is important. How does it relate to health equity principles and all? What is going to be collected, and as well as an opportunity to do a quick walkthrough from our colleagues in the ministry, especially the IT department, to understand, to give you an idea of actually how does this data collection looks like in the portal.
Samia, sorry, just a note, your voice is cutting in and out a bit, so just to make sure the microphone isn't covered and that you're close to it. Thank you.
Oh, okay, thank you. Is that better? Thank you for letting me know. I'll try to speak louder as well. So I was going to, we all know what the objectives of today's session is, so if we can just move in directly into why is it important to collect this information? We know that collecting social demographic data paves the way to a wide range of data uses, and the lack of it or the access to poor data creates significant barriers, especially around building accountability for health inequities. Data can be used to examine various health outcomes from the perspective of the social determinants of health to identify priority populations. Data can be also used to tailor programs and services based on the needs of identified populations, and furthermore address health inequities through evidence-based program services and policies. The image on the right represents an approach to data-driven equity work that starts from data collection, use, and also that centers this journey of thinking through starting with collection, identifying and reporting, improving and evaluating data, and keeping equity throughout all of the processes of the data collection journey. It's important to keep in mind that collection means to a large end measuring and addressing inequities. So basically there's no point of collecting if we're not going to spend the time to actually address observed inequities. Data collection also needs to be grounding and understanding not only the current context of inequities, but also the historical context, particularly when thinking about Indigenous, Black, and racialized communities, and also thinking through public accountability and community involvement as a core component for responsible data collection and use. more specifically ensuring that data is stored and used in a way that is responsible, that does not harm or stigmatize the communities where the data is collected from. Rather, it's used as a tool to better the lives of those communities. In the next slide, we all kind of remember how when this pandemic started, there was the stories of all being in the same boat, and soon enough we realized that we are not only in the same boat, we are not even in the some of us do not have a boat to be in. So the conversation has changed very quickly, and early on, some of the work that teams from PHO and other researchers have done is to understand, examine neighborhood level data, and thinking through neighborhood characteristics such as diversity, and noticing that people in most diverse neighborhoods were significantly more vulnerable to the transmission of COVID-19 compared to the least diverse neighborhoods. We know that community transmissions proves a significant larger challenges for also we understand that the use of neighborhood level data collection is an important factor to understand experiences. However, there was a need to collect and understand individual level data as well. And with that, we understand also that another factor that was important to understand neighborhood level data was also around when it comes to income and focusing on material deprivation. So equally early on, we found out that the percentages of confirmed COVID-19 cases was the highest numbers were also observed in the most deprived neighborhoods compared to the least deprived neighborhoods, the materially deprived neighborhoods. Another factor that we wanted to just think through as we are having this discussion is around language, knowing that language are linked to the determinants of health, and particularly that clients have different experiences based on language barriers that they might face, and that impacts their health outcome. And research also in Ontario particularly suggests that there are many issues when it comes to multiple municipalities in terms of access to healthcare services. The next segment that we wanted to move on is just understanding and grounding our conversation, even though many of you are experts in this field, but it's always important to kind of remember our basic principles around health equity. And health equity meaning that people can reach their full health potential without a disadvantage due to their social position or other socially determined circumstances. And more importantly, even though we sometimes use health equity and health inequity interchangeably, is to understand that health inequities refer to not only differences of outcome just because of inequality, such as, for example, people who are skiers having more opportunities to fracture their bones as opposed to those who do not ski. But rather thinking through health inequities as differences that are systemic and observed across populations. They are unfair and unjust, and they're also rooted in things like marginalization, discrimination, and exclusion. And more importantly, these differences and inequities are avoidable, and they are socially produced. We know that also the social determinants of health are the basis of how we experience wellness and health. Thinking through multiple social determinants of health, including not only the quantity, but the quality of resources that are available to people, such as where you live, depending on how many access to hospitals or health services do you have? Do you have safe park in your neighborhood to go for a run and to be physically fit? Do you have, do you have food security concerns and all of those things? We also understand that over 50% of our health is saved by those social determinants of health, such as income, education, social safety, social capital, gender, race, and also the other 25%, as just given examples given, are due to our access to health, which also, and wait times, which also are impacted by the first 50% in terms of our social capital and where we're at. The next slide, we wanted to touch upon Indigenous determinants of health, particularly because it's very important for us to know that Indigenous determinants of Indigenous health have additional and unique layers. And when engaging in discussion of determinants of Indigenous health and Indigenous health outcomes, we should be mindful of the potential cause of harm and further stigmatization of Indigenous communities through those conversations, particularly when we don't contextualize the historical, political, and socioeconomic conditions that have influenced in current Indigenous health. We also miss a significant piece of Indigenous history, including resilience and protective factors such as language, connection to land, ceremonies, and self-determination that have also played a significant role in Indigenous health. So thinking through this, we can look through 3 different levels of Indigenous determinants of health. The first one being proximal determinants of health. So at the service level, more observable impacts of health. So these include healthcare availability, access, physical environment, and health behavior. The intermediate determinants include factors that work at the systemic level and that are persistent and occur and influence different health experiences. These include community infrastructures and relationships, including kinship, networks, and knowledge sharing. The most important ones, and sometimes not talked about often, are the root causes or the structural factors in Indigenous health that manifest in historical, political, ideological, economic, and social foundations that, as a result, it acknowledges the impact of colonialization, the Indian Act, the residential schools, the 60s scoops, the Indigenous people's experiences with the Children's Aid Services societies, as well as protective factors as Indigenous worldview, spirituality, resilience, and self-determination. So in general, we wanted to think through that it's very important for us that through Canada to understand that these are the building blocks for health equity and the experiences of health inequities. That throughout Canada's history, colonial practices, including the oppression of Indigenous peoples and the enslavements of people of African descent, have shaped public attitudes, beliefs, practices, and continue to negatively impact Indigenous, Black, and other racialized communities in social, economic, and political life. Therefore, the health equity work should be grounded always in a number of approaches that recognize the history that they include. It's just important to understand the way we are experiencing this pandemic does not occur in a vacuum, that it has building blocks of such as building blocks that important approaches that we need to take, such as anti-colonialism approach that starts with acknowledging and understanding Canada's colonial history, as well as its own ongoing impact, recognizing Indigenous peoples' inherent rights, sovereignty, and right for self-determination. When it comes to health equity and data collection particularly, this can translate in engaging with Indigenous data collection experts on how to talk about indigeneity and how to store, share, and use such data. An anti-racist approach to this work means also that it's important for us to adapt act in ways that we seek to identify, remove, and prevent, also mitigate the racial inequitable outcomes, and address power imbalances between groups. Data collection and use are often powerful tools that can be approached. So data can be used for good or bad, and it is a powerful tool. It involves going beyond the interventions and working to change the structurals that sustain inequities. Using a systemic anti-racism lens means that racism is often discussed often in an individual level or an interpersonal level, such a joke or a racial slur that has been used. Those are important components of racial people's experiences, However, it's more important to address racism at a systemic level and to understand what are the structural policies and programs, procedures that keep racism and racial inequities in place. In the next slide, we wanted to just talk quickly about experiences of anti-Black racism as a determinants of health. That is different than general experiences of racism. Black Canadians have experienced discrimination at multiple levels of society, including interpersonal, institution, and structural discrimination in multiple ways. So when we're talking about experiences of Black people in terms of the housing, education, income, and food insecurities, and such continuous persistent experiences of racism results in chronic stressors and trauma that impacts people's both mental and physical health. All right, next slide. So just to think through, for this particular program, to think through what data is being collected. And I think in the next slide. Yeah, thank you. All right, I think I'm getting some notes saying that it's hard to hear me. So I'm gonna try to speak louder. All right, so the purpose is to ensure, so thinking through the purpose, the collection and the privacy of this data, the purpose is to ensure that everybody has equitable access to the vaccine, to determine where, how information about the vaccine can be improved for individuals to make informed decisions, and to inform and monitor vaccine rollout in communities facing disproportionate impact. So this is what we were talking about around collection, not for the sake of collection, but collection for a purpose, and the purpose stated here clearly. Consent is important. Consent is provided alongside other demographic questions. Individuals can choose to answer or not answer any or all of these questions. And finally, privacy information. This information is protected by the Personal Health Information Protection Act, PIPA 2004, and the information will be stored in a secured government data systems, disclosed only as permitted and required by law. Next slide. So one of the first questions that is going to be asked is about race. And race is a term that's used to separate people into groups based on skin color and other physical traits. Race is not based on biology or genetics, but on differences that society has decided were important. These differences have been historically and currently used to perpetuate racism, discrimination, exclusion, whether that is conscious or unconscious. The current list includes categories with the options of selecting multiple categories and adding another category. When capturing this information, you can use descriptions and examples provided here in the box to guide the respondents through how they're responding to the question. It's important to know that these questions include the wording of the categories, was developed by the Anti-Racism Directorate and took years of consultations around data collection and the best way to ask this question. There's also a script and a frequently asked document that we will be sharing that will help you guide through asking these questions to the clients. Next slide. This is, most of these questions are very similar, as Yolande had mentioned, in terms of the data collection work that is currently going around COVID-19 positive cases, except for ethnic origin, which is a new category. The term, so you might think, what's the difference between the question around race versus ethnic origin? And sometimes these terms are used interchangeably. However, they are different and they are connected but different. While race categories are socially constructed, as we've mentioned, and applied to communities, ethnic origins often are self-identified by the communities. They are learned or adopted by communities. And particularly, they describe characters such as language, practice, and belief. Health researchers examine race and ethnic origin together to enable more complex analysis of community needs and experiences. So, for example, a more in-depth experiences, understanding and analysis of experiences of Black communities will be understanding the unique needs of Afro-Caribbeans versus people from the continent. So African communities versus Afro-Caribbean communities. This list provides some examples such as that could sometimes be nationalities, but also ethnicity. So Chinese, Filipino, Scottish, Guyanese, Somali, Korean can also be an ethnicity as well as a nationality. Next. This is also an existing category that is currently being asked around COVID-19 positive cases, which is the conversation around income and household size. It's important to ask the person about the range of a range, as opposed to providing a range is a good way to understand and to create comfort around providing this information and understanding that people might have privacy concerns around this question. For persons not sure about their household income, it's important to ask a rough estimate and be able to provide this information. Again, the accompanied guide that we are providing will have a little bit more examples around the scripts that can be used and how this question might be asked to create comfort. The next question is around language and language that are spoken. We know that language barriers have had negative impact on people's experiences around health and seeking health services. In order to understand the language profiles, we're asked clients to both the question around language used first spoken around childhood, as well as the language used, official language used, whether it's English, French, both, neither, or do not know, or prefer not to answer. We wanted to include a note about indigeneity. We've talked about Indigenous experiences and Indigenous determinants of health earlier on in this presentation. And it's important to collect this information, but in a process in a way that is respectful of Indigenous culture, nationhood, and a way that also captures diversity of Indigenous peoples who access to public services, public health services. And we just wanted to make a note that to address health inequities faced by Indigenous peoples, the Ministry of Health continues to work with the Ministry of Indigenous Affairs and Indigenous partners. The final point that we wanted to bring up was around some things that we have observed around data quality concerns, and data quality continues to be critical for the success of this data collection process. There are a lot of small practices that we can incorporate at the point of data collection that will improve the quality throughout the process. The two pieces of information that we particularly wanted to focus on is around missing data, and the idea of trying to not leave data fields blank, particularly to if for example, the client or the participants do not wish to answer the question, to record it as preferred to not answer, as opposed to leaving it blank. Since when we receive blank data fields, it's difficult to understand if the question was not asked or if it was not answered. The other piece that we wanted to also flag for people is around trying to limit the use of the category of other, and try when an answer is provided, try to see if, where possible, if it can be confirmed. For example, if someone indicates their racial group as Lebanese, and perhaps asking if it would fit under Middle East. So reducing the use of the other category is going to improve data quality. I think for the next slide, I'm going to be inviting our ministry partners to just help go through and navigate the COVAX screen and the use of it.
Thanks, Samia. Yolande here. I'm not sure if any of our partners, our IT partners, are on the line right now, but in the interest of time, I might take everybody through the next couple of slides, and then hopefully if we have any questions, we can also address those at the end of the presentation. So what everyone is looking at right now is the screen that COVAX users will see with the newly uploaded or populated information around sociodemographic data collection. And this section of the, I guess, the general consent and check-in phase of preparing someone for a vaccination, this information is part of that main screen, as I understand it, and is sort of the next block of information down from the information that you would typically be collecting around name, address, and that other sort of standard administrative data. So as you can see here, the first step is really to do that client check-in and consent to capture the data in COVAX in general, because we're also collecting standard or administrative data as part of what we are doing, or what COVAX users and administrators are doing. And from there, after collecting the information that's required for that standard intake, if I could use that language, administrators would have the opportunity to ask the client if they're willing to provide their sociodemographic information. So you'll see on the bottom right of the screenshot that there is a drop-down area there, or an area that you can scroll to, that will actually allow you to select sociodemographic data and start a new record in that regard as far as this individual's consent and collection. Next slide, please. So on this screen, there's some critical stuff here, which pertains primarily to the consent. There has to be consent collected similar to the consent that's collected overall for entering information into COVAX, but there's express consent that has to be provided for the collection of the sociodemographic data. And there is in the COVAX system, as you can see on the right side of the screenshot, the consent statement is there. In many settings, as far as vaccination sites go, when it comes to consent, this is information that is shared verbally or read aloud to somebody who is consenting to the collection of their information in COVAX. And so the same scenario applies here with the consent for sociodemographic data collection, and you can see it on the right. I really want to underscore again that we don't want to be doing this kind of data collection without that express consent and that record being checked off in the system that consent has been provided. From there, you'd be able to move down through the categories that Samia already spoke about in terms of race, ethnicity, household size, income, and language, and be able to use those drop-down fields that she spoke about earlier to indicate the appropriate response based on what the individual that you're speaking to is telling you about their identity in those 5 respects. If there's a necessity to use free text, that option is available. However, we really do think it's important as much as possible to collect and capture information using the drop-down menus to ensure that there's some consistency in what's being recorded, and hopefully making it a little bit easier for administrators as well to not have to do too much interpretation of what should be in a free text box. And then from there, the record would be saved, and then you would move on to the next patient or client at the vaccination site intake. One of the things I do want to flag about this process is that this sociodemographic section has been entered into COVAX in such a way that it's not forcing entry at a particular point in time when someone arrives for their vaccination. So some sites, again, that collection of information might typically happen at the stage of intake or general reception, where an individual has come forward and is providing their information, their address, all these kinds of things. It could happen there. In some instances, there may be sites who are implementing collection of this type of data at the observation period or the recovery period. And so the system is structured such that you can do that. You don't have to go back through other work or other screens to start over to collect this information. You can enter into this workflow at any point in your transaction with the individual, if I could also use that word, or at any point in terms of the delivery of the health service, in this case, the vaccination with that person. So I see some questions in the chat. Sammy, I don't know if you want me to get into that now or if you want to wait until the end of the presentation overall.
So I think maybe you can just go through the rest of the slides, and then we're just the team is sorting these questions and we'll be bringing them up.
Okay.
Thank you.
So I think those are the close of that's the last of the system slides. So maybe I'll turn it back over to you at this point to wrap up the presentation for us.
Perfect. So just to wrap up is understanding that this work can be only done when we are able to embed equity practice throughout the way we are doing it, from data collection to analysis to use. And also, when we think about an equity perspective, we think that it is a continuous reflection on an understanding of how are we bringing our worldviews, our assumptions, and our beliefs to our work, being open and non-judgmental, being grounded in mindfulness, and paying attention and being purposeful and intentional on how we ask the questions, what questions we ask, how we understand them. And finally, building a rapport and trust to have conversations around and asking these questions in a way that does not stigmatize people and does not cause harm in any way. So I think we are going to be going into the question and answer section. I am going to invite Pam to facilitate that portion of our presentation.
Thanks, Samia. So there are a couple of questions that came in just privately to the host here that I'm going to take us to first, and then we can go to the ones that I think others are able to see. So I think the first question is, would these set of questions be available in the booking system rather than asking in a clinic setting?
Thanks for that, Pam, and thanks for wrapping us up, Samia. So at this point in time, when the booking system is launched, as far as what I know in terms of where we are at, it really will be focused on appointment booking, but the intention is for, at some point in the future, as the system evolves and matures, for this sociodemographic information to be entered if someone wishes to provide it. I saw a question in the chat about, is it mandatory? It's not mandatory. All of this information is voluntary. In terms of a person's willingness to provide it. But we're working with our IT partners to have that opportunity in the booking system in the future for this to be collected in advance and sort of a pre-registration. But what's being launched in the coming days or in the next week or so won't yet capture that.
Thanks. The next question that we received privately as well is, for household income, should we consider pandemic household income or pre-pandemic? Because some have identified that the pandemic has increased has affected their household income.
That's a great question. I think at this point in time, we leave it to the discretion of the individual. Most people might perhaps answer that question based on their current income status, because maybe there might not be assurance that their previous income status will return. So that's how I think we tend to think about it, the income status at the time of vaccination. But for us, I don't think we're being super prescriptive about that. It's really up to the discretion of the individual and what they want to share.
Great. I think the last one we received privately is this already available in COVAX? And I think this maybe was repeated in the general chat as well.
Yes, these data elements are now live in COVAX, and collection is available for administrators, for individuals who want to volunteer this information.
Great. The next question was, for people who have already received their vaccine, is there an effort to go back and fill in this information?
No, we are not doing retroactive sociodemographic data collection. That would imply there would be a need to have consent, express consent to do that. And so going back now and offering consent would sort of present a different set of challenges. So we're focusing on a go forward collection at this point.
Great. So we're at the next one here about whether the data collector should read the entire consent, and is there a shorter version available that's more plain language?
I appreciate the question there and the challenge with that section being a bit lengthy. That is the consent that we are asking that vaccine administrators read. It is a legal document, so we have to be mindful. When I say legal document, what I mean to say there is that what you would see on a paper form, for instance, is what's reflected in COVAX. And so the person has to be fully aware of the decision that they're making in terms of providing this information and how it will be used. So we would ask that that whole thing is read as scripted.
Thank you. The next one here is there a printable format of the questions that the client can read along? When collecting information verbally, there's an issue at the site regarding noise and the volume of people being processed.
Another great question. There is a paper version, like a hard copy version of this consent form that I think has been posted or will be posted for situations where electronic capture is not available, although of course it's our strong preference that electronic capture, and I think for everybody's sake as well, is probably easier from an administrative perspective. But I think if there's a need to have somebody be able to read that information privately or in a more quiet sort of setting, the actual paper form would be a good alternative.
Great.
Not necessarily to capture the information. I just want, if you have the ability to fill it out electronically in COVAX, that's what we are hoping should happen. Again, just for ease of data capture and not having to go back and do post data entry, but the form may be useful for people to read so that when they're answering those questions with the administrator and entering into COVAX, it's more straightforward.
Great. Another question is, are Indigenous people to be entered as another race category?
At this point in time, we are not proactively collecting data about Indigenous people. As Samia mentioned earlier in the presentation, we continue to have discussions with Indigenous partners about the capture of information regarding Indigenous communities, and also how that is captured in terms of the identifier that we would use, or identifiers that we would use. So we wouldn't actively encourage that. Of course, an individual has the right, if they wish to indicate their indigeneity by using the other category, but we are not suggesting proactive collection to that end at this time, because our priority is working with partners to do that in a way that has been endorsed by Indigenous communities and partners.
Great. The next one is, if this information is not available, can the patient still receive the vaccine? For example, if consent was obtained prior to implementation of the new fields, and then the vaccine is given post the release of these fields.
So again, want to reiterate or underscore that this is entirely voluntary. The decision to provide or not provide this information has no bearing on a person's ability to receive the vaccine. And we're very mindful of that in respect of ensuring that it doesn't create, feelings of concern or hesitancy among individuals. So it's voluntary collection, it's collection by consent. A person can answer any or all of the sociodemographic questions or none, and making any of those choices does not preclude them from receiving a vaccine at any time.
Great. The next question here is around feasibility. So if the assumption is that clinic staff would sit with the client and ask the questions, it may not be feasible. An intake could ask the questions if they wish to submit. So just at what stage in the process and where it's most feasible to capture the information.
I think that's an important question that I'll try to provide some parameters for, but understand also that different sites are taking different approaches, locally sort of focused approaches in different public health units based on your protocols or your setup. But there are 3 potential opportunities where this information could be collected. One of those I've already spoken about, which is the future opportunity around the booking system that we're working on. The second would be at that intake phase with a reception staff person. Then there's the opportunity at the same time with an administrator, and then I guess there may be 3.5. And then in the recovery period. From our perspective, again, we're not going to be prescriptive about that. I think it's based on what sites do and the workflow that you've established. However, we do recognize that it would probably be quite onerous to the process to have the actual vaccine administrator undertake this consent, this part of the consent around sociodemographic data collection before giving a vaccination. So I think for us, it makes sense that an intake staff person or somebody performing the reception function is the most likely place where this would happen, just to ensure that there is, you know, as much efficiency as possible in moving patients or clients through the vaccination site.
Great. The next one is, will the consent be available to read in French to the client?
So we have provided, I haven't sort of seen in, you know, the system in terms of what it looks like at this point in time. The screenshots that you saw in the presentation are reflective of how it looks, but both English and French information and consent language was provided to our IT team. So I imagine that if you're using the system in French, you're going to see that information in French also, but that's something that I'll double check.
Another question is, for people of mixed race or ethnic combinations, can more than one category be chosen? So currently in CCM, we have to use other to add the second category in text.
I'm not sure if any of our IT partners are on the line. I'm not 100% sure if you can actually select more than one item from the drop-down menu. So this may be a situation where there would be a necessity to use the other category if an individual is indicating more than one thing, but that's something that I think we can also follow up on.
The next question is it mandatory to collect all sociodemographic data fields from all clients, or can authorized organizations develop their own plans and methods? So I think if I'm understanding this question, it's about the full set of questions versus individual questions.
So the individual has the option to answer all or none or some. It's up to them. And the administrator would then accordingly record that in COVAX. If they want to provide, for instance, their race, but not their ethnicity, or their income, but not their race, it's up to them how they would like to answer and what they would like to answer.
Another question here is, will the authorized organizations get access to their sociodemographic data, and if so, when?
Sorry, could you repeat that question?
Will authorized organizations get access to their sociodemographic data, and if so, when?
When we say authorized organizations, is that a reference to public health units, or what is that?
I might be reading into it, but I think that would be an example.
Okay. So the work around access to the data that is being collected in COVAX is an ongoing piece that's happening in the ministry with some of the partners who we've worked with to make this happen. And I can say, I can't maybe provide as much of an answer as you would like, but I can say that there's an understanding of that priority, and that the work continues to see what can be done in terms of increasing access for sites, especially public health units in particular, to access information being collected in general, broadly, through the vaccination system.
Great.
I do want to just flag one thing. I saw a clarification in the comments from someone who said that you can enter multiple fields in COVAX. I think that was in reference to the question around, you can select multiple entries. Sorry, from Hannah Fleischer. Thank you for that. In respect to the question about a person identifying in multiple ways, I think that's probably what that's about.
Another question here is, what is the plan for ongoing training and support for the extensive list of health professionals that will be administering the vaccine moving forward? Noting that pharmacy is one of the groups, and I talked about it at the beginning of the session.
Yeah, a great question there. So we recognize this as an ongoing initiative, even though the fields are live in COVAX at this time. We don't sort of have a sense that this is the end of it. One of the things that we are going to be doing as other healthcare providers come online to participate in vaccination administration and distribution is, first of all, this is going to be made publicly available, I believe, this webinar that Public Health Ontario has worked with us on and done so much great work on will be posted, so folks can access this even after this session. But in addition, we're working internally to be in touch with the professional colleges of the various professions that will be involved in this, to think about channels of providing this type of information for them as well.
Great, so there's still more questions coming in. I think we will have to cut off right at 12 o'clock, so we'll try to get to a couple more. So will there be an opportunity to collect with the second dose?
That's a great question. I think for folks who have not, for instance, have already received their first dose and are coming in to do it at the second dose, yes, my understanding is that there would be an opportunity at that time to collect this information as well.
Great. There's a question here about the training and development materials that are being provided to support these questions, like the frequently asked questions, and maybe Yolande or Samia, if you want to comment on materials that support this.
I will just jump in and say that there is a frequently asked questions document and a script that has been developed, and that will be provided to all COVAX users after this call. But Samia, over to you.
Yeah, so I was just actually going to let folks know that we have a final poll that asks around interest in the type of next trainings, and we will also take the time to go through the chat to potentially address any of the questions that we haven't had a chance to address today. So please feel free to continue putting your questions in the chat. Caroline, can we share the last poll? Great, thank you so much. We just wanted to let you know that we'll be sharing the frequently asked questions with the script alongside the PDF of these slides, as well as addressing maybe any additional resources and questions that you might have. We are grateful for this opportunities to co-present with Yolande and her team and do this work, and looking forward to supporting the field as this work and project is launched. Thank you so much, everyone. Have a wonderful rest of your day.
Thank you very much. Appreciate the time, and thanks again to our friends at PHO for the good work.